So what I'm going to do is I'm going to have this interactive session. So please take out your phones and go to either slido.com and put hashtag DXEX, or you can just do this QR code and then go directly to Slido. And we're going to do some interactions. All right. Okay. So let's do a question. Let's see if we can get this to work. Does your practice or hospital encourage providers and staff to report opportunities to improve patient safety without fear of retribution? So far, 2 of you say yes. 4 of you say yes, sometimes. Okay, very good. Okay. So here's a real story of a very tragic case of misdiagnosis. So Rory Staunton was a 12-year-old boy who came to a New York City hospital emergency room with what seemed like gastroenteritis. He was sent home, and the next day he came back because he was really sick. He then went to the ICU, and he died 3 days later from streptococcal sepsis. What happened during the first emergency room visit was the people taking care of him did not see that he had mottling of the skin. He had black spots on the skin, but physical exam was not done, and that was not picked up. You never get mottling of the skin with gastroenteritis. Also, he had a white blood cell count of 15, and he had bands of 54%, which suggested that he was having sepsis when he came in the first time. This is a very tragic story. The number of patients who have misdiagnosis every year has been quantified and estimated in the United States at least, and that's about 5% of US adults. So about 1 in 20 US adults are going to have a misdiagnosis at least once in the year. So that's a pretty high number, and that's in the outpatient setting alone and doesn't include children like Rory Staunton. So the number is quite large. Now, how do you define a diagnostic error? So there was a report by the National Academy of Medicine, which is the highest academic body in the United States, that says it's the failure to establish an accurate and timely explanation of the patient's health problem or communicate that explanation to the patient. Now, you realize that there is an or between A and B. That means you can have either one of those, and they call it a diagnostic error. Now, in research, so I do a lot of research on the topic, and I study a lot of patients who have had diagnostic errors. We take a very practical definition to diagnostic errors. We call them missed opportunities to make a correct or timely diagnosis. Now, these missed opportunities could be due to either thinking issues, so there could be a decision-making problem, or it could be due to system issues, system problems, communication, teamwork, being very busy, chaotic, time, productivity pressures. And a lot of times what we feel is it's an interaction between the two. The harm from diagnostic error occurs mostly when there's a delayed treatment or a delayed test or a wrong treatment or a wrong test, and that's what leads to the harm. So in our work, we focus on areas A and B on that slide. Not all the diagnoses can be made in a timely fashion. There's a lot of rare diseases, rare conditions. So what are the most common conditions that can cause the problem? From malpractice claims, there's 3 kinds of diseases that stand out, and if you look at them individually, you see these are fairly common conditions. Cancers, cardiovascular conditions, infections. If you think back at Rory Staunton, the 12-year-old boy, he had sepsis, so that's another common reason. But what's more important is no specialty is immune. So whether you're a radiologist or a pathologist or a dermatologist, you're going to see diagnostic errors of all kinds. One of the major findings that we have from all the research that we do on the topic is a lot of these are not just common conditions that are missed, but also the missed opportunities are related to basic clinical skills, history, physical exam findings, the basic data gathering process. That's where most of the diagnostic errors that we see happen. With electronic medical records, overlooking information within the electronic health records has also come up to be one of the common problems why this happens. What about contributing factors? There's many, many reasons. Some of them I mentioned earlier. There's data gathering issues, communication issues, knowledge problems, biases, heuristics, test results interpretation problems, language issues. There's lots and lots of reasons for why this happens. And one of the things we have tried to focus on is, this problem of testing, whether you sometimes want to test the patient. We're also constantly balancing between should I order the test or should I not order the test. So there's a lot of uncertainty involved in the diagnostic process. If you don't test the patient, you might miss the diagnosis. If you do test the patient, you might actually be ordering a very expensive and a harmful test. So most doctors are struggling between this tension between should I order the test and should I not order the test. On a daily basis, we do that. So how have we described diagnostic excellence? Diagnostic excellence is not just about making a correct and timely diagnosis. It is also making sure that you get the correct and timely diagnosis using the fewest resources. So if I order a CAT scan on every single patient who comes to my clinic with a headache, I might pick up a brain tumor in maybe 1 in 200 or 300. But that's not good use of resources. So that's why that's a trait that we need to have for diagnostic excellence. You also need to maximize patient experience. You need to acknowledge uncertainty. As I mentioned earlier, there's a lot of uncertainty involved in the diagnostic process. And then we also have to sometimes wait. And waiting is not something good that we do. We always want to jump to a diagnosis, but sometimes we have to wait to make the diagnosis because the treatment may be really harmful. So we wrote a paper in the BMJ last year which talked about what clinicians can do to achieve diagnostic excellence. And I'm going to quickly walk you through the 5 strategies we proposed in that paper. And the paper should be easy to access, but I'm going to give you the main points in a minute. So let's do a little poll again. If you miss a patient's diagnosis, would you like someone to let you know about it confidentially? Let's see what people say. Go to slido.com, #DXCX, and tell us what you think. So 4 people say yes, they want to hear about it. All right, so no, I've never missed a patient's diagnosis, obviously. I'd like to talk to you after the talk. Please come and talk to me, whoever said no. Okay, so there's a concept called calibration that we'll be working on. Calibration is the alignment between the accuracy of my diagnosis and the confidence that I have in that accuracy. So what we did was we gave cases, so these were real cases, to 120 internal medicine doctors. And we asked them, can you solve the cases online for us? These are real cases. And we unfolded the cases, history, exam, and then physical exam sort of findings and tests, just like a case would unfold in real-world practice. And we asked them, can you give us a differential diagnosis on this patient and tell us how confident you are? And for every time we asked them, give us up to 3 differential diagnoses. So what are the 3 types of diagnoses the patient can have? And tell us how confident you are in your diagnosis or in your differential diagnosis. And what we found was that physicians were overconfident because we gave them easy cases and we gave them hard cases, and their confidence didn't change between the easy and the hard cases, but their accuracy dropped dramatically, which means if in the middle of a very difficult case, so we had the cases, easy and hard, in a very difficult case, they were still very confident about their diagnosis. And that was because physicians were overconfident, and that's why you see this sort of study. By the way, we also asked them, would you like to seek help in the middle of that case, a difficult case, both for easy and difficult cases? We asked them, would you like to seek help? And they said no, which means that they were overconfident in their abilities. One way that we can change overconfidence is by giving feedback about performance to the physician. So if I know how well I'm doing in my practice, about how accurate I am in my diagnosis, I should get better. And Gopi, my colleague, is going to talk more about that. But what I want to quickly tell you is the first strategy we proposed was you must seek feedback on your diagnostic decisions. Why? Because you can get better calibrated. You get better aligned between the confidence and your accuracy. And You can do this in your practice. Just maintain a list of patients that you see and look and see what happens 2-3 months later to them. Ask your colleagues how you're doing in your practice. There's other ways to do it now. We tested this at a health system in US, Geisinger Health System, where we found a whole lot of diagnostic errors, and we went and talked to the clinicians in a very confidential, non-punitive fashion. And we told them, this is what happened in your case. And we tested this, and the clinicians actually received this really well, and they found this to be a learning experience, somebody coming up to them and talking about some of the errors and mistakes that they had made. Another resource that is now available for free on AHRQ website, so if you just Google the word Calibrate DX, you will find this new resource. It figures out how you can do feedback on your own cases. So you can go to your own cases, look at them systematically, and learn about your own patients. And it tells you where to go improve on. You can also look at your charts. You will look to see if you find this instrument online. It's freely available. It's called Revise Safer DX instrument. It helps you review your patient's medical record to sort of see, did you make the right assessment? How was your clinical reasoning? Did you make the right decisions at that time? You can go back and look at your medical records afterwards and learn from them. All right, so next strategy is what we call bite-sized practice. Bite size is small bite, okay? So it's like a, from digital applications. So there's a lot of cases online now. And you can learn. Not anybody has the time. So most of us are very busy. But can you spare about a few minutes a day, maybe a few minutes a week, looking at short cases? So there's a lot of cases now that are challenges that you can go and look and see, can you use this to improve your knowledge? So there's a lot of resources that we mentioned in the paper where you can go and look at the cases and just every day or maybe a few times a week, practice those cases and make sure that you're learning at the same time. Because, we don't have time to read Harrison's for 2 hours or 3 hours a day or 2-3 hours a week. But we can do these small bite-sized cases and learn from them. Okay, let's go to our next poll. When I see a difficult patient, I'm comfortable seeking patient and family feedback to identify and understand their diagnosis-related concerns. All right, everybody wants to do that. One person said no. Hopefully you'll find maybe some of our strategies useful. Maybe a few more people said no. Okay, next slide is for you. So we got to consider biases. We all have biases, all right? And there are ways you can use sort of this thinking to sort of promote humility. You can encourage awareness of your own sort of thinking and how you may be vulnerable to biases, and you can improve your recognition. And we give certain examples of how you can do that, how you can build empathy, consider alternative diagnosis possibilities if the patient was somebody else, So think about those. So we talk about biases in this paper as well. Let's go to the next poll. For the next strategy, our practice or hospital encourages direct collaborative interactions between treating clinical teams and diagnostic specialties in cases that pose diagnostic challenges, which means you actually go talk to the pathologist. You actually go talk to the radiologist or pick up the phone maybe. How many of you do that? So about half and half is split. Some of them, okay, there's a few more people doing the poll. Okay, somebody says, no, it's not encouraged and not done. So this is another way to think about diagnostic excellence. I'm going to give you an example, but let's do the next poll. I encourage patients to review their online health records so they can check my notes and test results. Okay, never thought about it. Hopefully you will now. Okay, well, hopefully this would encourage you because, one thing we promote is teamwork. Diagnosis is a team sport, right? So you need to engage patients and other colleagues including radiologists and pathologists who may not interact with you directly in making a diagnosis, including nurses, including physical therapists. There's many people who help make a diagnosis. It's not just something that only doctors do. And this group decision making is really important. And now technology is becoming a part of our team too. So using technology wisely. And the last strategy is critical thinking, something that we all would strive for. But think about, the patient with headache who may be 55, who comes to you and the headache is not better. Well, you got to think about it. It's a new onset headache. Is it really migraine? Could it be something else? Could it be something more serious? So questioning your own decisions is really important. Going back to the patient and gathering more data after you see them, because if they're not getting better, you need to go back to the patient, get more history, do another physical exam. All that is very important, and all that is part of critical thinking. All right, so now that I've given you those 5 strategies, would any of you like to kind of use this as a career-long habit? Just pick one. Which one would you like to do in your careers? Feedback? Okay. Critical thinking, very good. And again, the BMJ paper is, again, very available to you, and hope you'll read it. Now, let me move in the last few minutes to moving from an individual clinician, what you can do, to as a hospital or a health system where you practice, how can your health system get better? So in all health systems, there are ways you can improve quality and safety. And we propose this model where all hospitals and health systems should become what we call lead organizations, and LEAD stands for Learning and Exploration of Diagnostic Excellence, where they need to do these 5 things. They need to create a virtual hub to try to understand diagnostic errors. They then need to do some measurements, find these diagnostic errors and figure out what to do with them. In fact, my colleague Gopi is going to talk about how she has done a project on this. We've got to create an accountable culture for our patients. And then we need to engage clinicians in improving diagnosis. We can't do this without engaging clinicians. And the way we want to get to this lead organization concept is we create a learning health system where it's just not one clinician or one physician, but the entire health system that is striving to become better. And the way to do it is, if you want to create an initiative in your organization, you figure out, you do a risk assessment, you gather data, and then you take actions to change practice. So there's a lot more that is coming in this area, and it's just not about a single physician making a diagnosis. One way that the health system, your health system, for instance, can engage you is by reporting. How many of you have reported a diagnostic error to your quality and safety leadership? Anybody reported? So a few hands up there. Okay, so if you find a diagnostic error in your practice or you see a diagnostic error, it could be a learning opportunity for your health system. So there are now people who have tried to engage physicians in a very non-punitive fashion so that they can report diagnostic errors to them so that they can learn from it. The goal is not to punish people, but the goal is if somebody made an error or they saw something, they need to report about a diagnostic error so that we can study and learn from it. So how do we get towards diagnostic excellence? It's a major problem. I've showed you the data, but there's been lots of good progress recently. We've got several promising strategies for clinicians, and I'll walk you through all of them. But also, don't forget, this is not just a clinician issue, but it's a system issue, and your health system needs to do something about it as well. All healthcare organizations can do something about it. I want to thank all my funding agencies. I'm going to hand it over to Gopi Asik, my colleague now. Thank you.